And now we're going to hear from the state of Georgia, the Crisis and Access Line, with Gwendolyn Skinner, for the Director of the Division of Mental Health, and David Covington, the Chief of Adult Services. Thank you so much.
Thank you for the opportunity to be here. Prior to my appointment as the Director of Georgia's Division of Mental Health, Developmental Disabilities, and Addictive Diseases, I served as the Deputy Commissioner of Georgia's Department of Juvenile Justice. Nowhere is the lack of behavioral health services more evident than with this special needs population. Lack of access to services for these children presents more than just juvenile delinquency. It contributes to the dropout rate in school, teen pregnancy, poverty, homelessness, and unemployment. I knew that Georgia's children who were involved with the justice system were not getting services, but was not exactly sure why that was happening. With my appointment as Director of Mental Health, which was proof positive, be careful what you ask for or what you complain about, because I became the Director of Mental Health and came to understand that the number one problem was a lack of access. Treatment works if you can get it, and to be effective, it must be immediately available when the person is ready for intervention, or else you miss the opportunity that may only come your way one time. We decided that we were going to put into place a system of real access for the citizens of Georgia, not an information and referral hotline. We had more than 25 of those, but a system of access to services. Before we could begin the work of developing the system that we envisioned, Hurricane Katrina hit, bringing tens of thousands of traumatized people into our state, underscoring the lack of access to services. Now, their needs were in addition to the needs of Georgia's more than 9 million people spread over almost 58,000 miles in 159 counties. We have a very complex state. What began as a vision became a mission. So we selected Behavioral Health Link, a provider that understood our business and shared our vision and our sense of urgency. My experience tells me that no one really expects innovation in the mental health system. However, the integration of technology with actual service delivery is unique to our system. It has resulted in a system used not just by individuals and families seeking help, but also has become a tool that is used by judges, frontline law enforcement officers, schools, Veterans Affairs, Children's Services, Aging, Corrections, and all other state agencies. While the immediate impact and most important achievement was actually getting people connected to services they need and providing a choice of qualified providers, the lasting impact has been to have the real data to know who in Georgia is seeking treatment, the types of treatment that they're seeking, and where treatment is available. Rather than relying on prevalence data or historical funding allocations, the technology has allowed us to take our finite resources and direct them to where the actual need is. More importantly, our citizens have a renewed confidence in our behavioral health system and our ability to respond to their most immediate need.
Georgia has introduced a new language of public sector crisis and access services and revolutionized the expectations of state governments around tangible outcomes, real-time actionable intelligence, around the dramatic improvements in entry to care and substantial cost savings. Reaching out for help with a mental health or substance abuse problem can be like picking up the 400-pound phone, but the Georgia Crisis and Access Line has made the process fast, friendly, and easy. Last year, 12-year-old Julie was struggling with depression and thinking suicide would be easier. It was a Sunday afternoon, her parents were not home, and she knew the location of her father's rifle. Ambivalent, she called 800-715-4225, and a trained clinician engaged her, collaborated with mom and dad, and immediately scheduled an urgent intake. Now, what Julie and her parents experienced was personal contact and collaboration, but behind the scenes, that clinician was empowered by advanced technology with coaching, prompts, and a wealth of resource information. But what has really captured the attention of state governments is the scale and scope, because on a daily basis, the Georgia Crisis and Access Line is receiving more than 1,000 calls like Julie's and has already amassed more than 1 million calls into Behavioral Health Link. An advanced dashboard management system continuously rolls up detailed data for operational management and for strategic planning. Instead of 3 weeks to 3 months, which is commonplace nationally, appointments are now available within 5 business days, and an advanced algorithm informs the educated choice of providers. The costs of doing the right thing: without this service, Georgia would have experienced an additional $50 million in inpatient services since July of 2006, a figure which does not include the impact of diversion from emergency departments, law enforcement, and jails. Calling crisis and access is a tremendous innovation for the system, but for callers and their families in crisis who rely on a quick answer night or day, it is the first step for personal wellness.
Wow. Okay, Ellen.
So one of the things that we're interested in is the relationship between the state and the provider, the for-profit provider. And I wondered who owns, for instance, the new call center software package, CCID?
The software is owned by Behavioral Health Link. It is in a partnership with the department. And Gwen, do you want to speak a little bit to the relationship?
We initially had 25 single points of entry in Georgia, and that was not working for us. It was a combination of both not-for-profit and for-profit. We decided to do a request for proposals and put that out. When we did that, we had 5 responders, all of them for-profits. And so for us, from a business sense, we decided we really didn't, it didn't matter to us if you were a for-profit, not-for-profit. What we were interested in was the outcome. And that's how we responded, simply to the quality of the proposal and the cost.
But if you, in future years, when you rebid this, how confident are you that you will be able to maintain this system if some of the technology is proprietary?
Sure.
You know, this is certainly an issue that was raised by the department from national experience with other hotlines. And there were a couple of things that, one was that was required by the RFP and one that we offered up from Behavioral Health Link. The number itself, the toll-free number, it does belong to the state of Georgia. And so in future bids, unlike if you're familiar with the FCC issue around 1-800-SUICIDE right now, that number would be perpetuated by any other vendors for the future, and so that's the asset of the state. We went one step further. We have a website that provides this information to the public, and we offered up that website URL will also belong to the state in perpetuity. And so it really is a partnership around solving that. But let me speak just one step further to the issue of the nature of our company. I think we bring 3 things to that as a for-profit or a small private company. The first is passion. The second is the speed. And the third is our geography. You may be familiar that the National Institute for Mental Health and NAMI have really talked recently about the 1 in 4 campaign, that 1 in 4 individuals in the United States has a mental illness in any given year. 1 in 10 children has a severe emotional disturbance. Our team, our ownership, our executive team, our staff is comprised of individuals who are survivors of suicide, who are recipients of mental health services, our family members. So this is a real passion to us and we care about this. In terms of speed of access and specifically to the issue of the software, this is the 51st year of crisis services in the United States. And for the first 40 years, there was no software, 45 years even, almost 50 years for some agencies. And what we've done since partnering with Gwen in July of 2006 is built a brand new software system that we've made 310 revisions to in real time. So when we get feedback from the department, we change it right now. So when you talk about a product, it doesn't exist tomorrow as it exists today. And it will continue to change, which has allowed us to do some things. For example, when SAMHSA introduced a new lethality assessment tool last year, we had already been operating that tool for a full year previously, and it's mandated and baked into the software. So we believe that's a real strength. Finally, the geography. The company is not, a lot of not-for-profits are focused on a core mission and a geographical center, whereas Behavioral Health Link was focused in Atlanta, Augusta, and when we had the statewide opportunity grew, we're now talking to Colorado, to Tennessee, to Louisiana, and have provided consultation to a number of other agencies across the country.
Okay, thank you. David?
your data about getting people appointments within 5 days and so on is all incredibly impressive. What I wonder is, if you were doing this piece really well, but the organizations and people who were actually doing treatment for these folks were doing a really bad job, that would be a little less impressive. So do you have data about the outcomes for the people who use your service and their satisfaction with the referrals that they get?
We have data on the connection of people. Through BHL, we know that they have their hand on the person until they are connected to services and then are able to ensure that the person does, in fact, make it to the service. From an agency perspective, we have revamped our system and enhanced it so that we now can track and see how long the person is engaged in service, how many encounters they have with our service delivery system, the type of services that they receive. That has been a tremendous improvement to a system that historically had been just enrollment of people in services. So we can actually tell you now where people drop off out of services. Now, the next step is to get to exactly where you're talking about. Take that data and determine why do they drop off at this point? What is it that is going on at that place in our system that is causing that? So we are ramping up for that now. Have some limited capacity for that, but that is exactly where we're going.
And let me say, in addition to linking individuals into a credentialed and accredited network through the department that is externally reviewed by an entity every quarter, we're also looking at integrating the feedback around the quality and an ongoing measurement into the algorithm that provides informed choice for the caller. Right now, that algorithm utilizes where they're located, how quickly they can get into services, but we want to advance it to the next level. The other thing we're doing is partnering with Dr. Thomas Joyner out of Florida State University and working to replicate the follow-up approaches that have been published out of Rutgers and Columbia University with Dr. Madeline Gould and Dr. John Califat, because we really want to get to the point that we take right now we have 250,000 triages, begin to do research on that and work toward obtaining a qualification with the National Registry of Evidence Practices and Programs. And really that's going to mandate the follow-up that occurs and the evaluation of the quality of that service in an ongoing fashion. We want that information to be available to the caller on the front end. So it's a real informed choice for them, and that's the direction we're moving.
Just one brief question. So you do mental health. Do you do drug addiction, alcohol and drug addiction?
Yes, we do, using the same line.
Well, I have to say this is really, really impressive. And there's a company that works with you that helped develop this, right? And you represent the company?
I do.
And how large is the company now?
Oh, we have about 100 employees.
Great. And you're trying to be in 5 states at the moment?
That's our goal, to be in 3 to 5 states. Right now, we're the statewide vendor for the Department of Human Resources in Georgia. We provide not only the crisis and access services, but mobile crisis, disaster response, community education, and other services throughout the state.
But you're in Arizona.
I work, in the last 2 weeks, my family has moved to Arizona, and I was hired by Magellan Health Services because of some of this expertise around taking responsibility for this, actually the nation's largest public sector behavioral health contract. It's a 3-year, $1.5 billion contract.
Well, does that have anything to do with your old job?
No. Let me follow up with that.
I'm a little confused.
Sure. I started with BHL in 2002.
You're representing your old company.
That's correct.
But in fact, you've left your old company.
Yes, that's correct.
Got it.
But that raises a question for me, which is what makes this effective is this close collaboration between the state, and particularly mental health, and this nimble, relatively small private company. Does that partner, in order to replicate this, doesn't that partnership have to continue elsewhere? Could it be done by a state alone without a nimble private partner, or B, by the state with a much larger partner that didn't have the intimacy that BHL has had with the state of Georgia.
Right.
Or Magellan could figure it out.
And
Well,
Magellan was one of the
Magellan's pretty
bidders
big.
on the original contract. Certainly, what we're trying to talk about is a series of principles, and I think there are three. You hit on one of them. Not just collaboration, but electronic connectivity between the provider community, 250 sites, 100 agencies, private and public sector, and under the department's leadership. Not just collaboration or partnership, but true e-connectivity has been what we think is the strongest piece. The second thing is not a referral and information approach, as Gwen mentioned, but direct linkage to the services. Again, Gwen was talking earlier about the concept of air traffic control. We own the plane until it's safely on the ground. That's not the approach of information referral over the last 50 years. And the third thing is the real-time data for strategic planning in a web-based approach. So yes, that could be replicated in other areas, but we think the alchemy of this unique relationship is one we are trying personally to replicate. Gwen and I spoke to 44 states' mental health directors a couple of years ago about this prospect. And I don't know that Behavioral Health Link would be interested in doing this in 20 states because you would lose it. We're interested in 3 or 4 or 5 kind of key partners where we have that robust type approach of what we've created successfully in Georgia.
Do you have to rebid this, Ms. Skinner, at some point, this contract?
I'm sorry, I didn't hear.
Do you have to rebid this contract with BHL at some point?
Yes, we do.
And when will that be, or do you know?
The rebid on it is in...
The original contract was for 5 years, and we're just finishing the 3rd year of that contract.
Right.
And when you rebid it, what kind of, maybe it's maybe a premature question to ask, but in light of Mr. Covington's answer, what kind of constraints do you think you'll put on who the prospective bidders could be? Do you know yet, based on your experience to date?
I don't think that we would have any constraints that we had not had in the original process because the original process worked for us. And we ended up with a vendor that could perform and be nimble and be responsive to the agency. So from my estimation, that could have been a large agency. It could have been a small company, a large company. It really was, could they get us the outcome that we wanted? And the outcome that we wanted is the air traffic or control approach, which is hold them in your hand until they are connected to services, and then give us the opportunity to develop the capacity to ensure that they are penetrating our behavioral health system, which historically has not been the case not only in our state, but in states across the country.
There were 2 conditions in the original RFP. You could not be a direct provider of services. Correct. So that there's no conflict of interest between the referral and the delivery. We're always linking someone with a service outside of our own. Right. That was a key component.
Thank you very much. It's really impressive to see that you could call up and get help right away. I mean, there are a lot of people who need that help, and the fact that you're providing it is really, really impressive. So congratulations.